And the title of his presentation is Multiple Myeloma, Stemming the Clonal Tides.
Hello, hopefully you can see my video as well as my screen that I'm trying to share right now. Can everybody see my screen? Everybody hear me?
Yes, we can.
Awesome. Thank you very much, Dr. Jalul, for the kind introduction, and thank you for the opportunity to present here at the TCGA conference. I am a first year, or I'm a molecular fellow this year, and the title of my talk is Multiple Myeloma, Stem the Clonal Tides, and Dr. Patel always asks us to choose a quote, so the quote for the day is "Never give up," for this is just the place and time that the tide will turn. This is from the famous American author Harriet Beecher. So a little bit of background about myself, since this is my first talk here. So I did my med school from India, from Calcutta, and then I moved to University of Rochester, upstate New York, for my PhD. I did my postdoctoral fellowship at Mayo Clinic, and then just before joining here, I completed my AP residency at University of Minnesota. So the outline of my talk today is going to be, we're going to discuss the epidemiology and diagnostic criteria for multiple myeloma. And we're going to go into the molecular pathogenesis and then describe in detail the few particular molecular events. And then the state-of-the-art or current prognostic and therapeutic strategies. And then we're going to talk about the challenges and then possible new solutions to them. So let's start with the disease burden. So multiple myeloma, it is the second most common hematologic malignancies, and it represents 1.8% of all cancers. As of 2022, there are a little over 34,000 new cases this year, and over 12,000 deaths this year. This is from the SEER database, and there's a slight preponderance to African American male. There's a high rate of early relapse. Early relapse is defined as relapse within 1 year. It's as high as 16%, and late and overall relapse goes as high as 85%. And then the 5-year survival is close to 58%, and this is defined by the state of the disease. Localized disease have a better outcome, and whereas distant disease or disease affecting multiple sites have a lower 5-year survival. So multiple myeloma, as described by European Hematologic Association, or the ESMO, the European Society for Medical Oncology, is clonal bone marrow plasma cells greater than 10%, or biopsy-proven bony or extramedullary plasmacytoma, and either one of these. So evidence of end organ damage characterized by the Kraft symptoms like hypercalcemia, renal insufficiency, anemia, and osteolytic bone lesion, or positive biomarkers for malignancy, which is greater than 60% clonal bone marrow plasma cells, serum free light chain ratio exclusively more than 100%, and more than 1 focal lesions in MRI or other forms of imaging with size more than 5 millimeter. So in this talk, we're not going to go into a lot of details about the clinical aspect of the disease of multiple myeloma, which is well characterized. The diagnostic criteria are very robust, but we are going to focus on the little bit about the bone marrow aspect, the testing aspect, and the molecular aspect of the disease. So piggybacking on that, WHO also defines myeloma as the presence of diffuse bone marrow infiltration with plasma cells, and you can see the plasma cells here. You can see these cells with distinct eccentric nuclei and binucleated forms are predominantly there in the bone marrow. And this or the presence of serum or urine monoclonal immunoglobulin markers and evidence of present end organ damage or risk of end organ damage within 2 years. So this is the WHO definition of multiple myeloma. And now, so what are the testings that are done from our diagnostic point of view from the bone marrows? So at the time of diagnosis, cytology and biopsy-proven multiple myeloma is defined as plasmacytosis and monoclonality. And this is also needed to show complete remission, or absence of this is needed to confirm complete remission. Flow cytometry or NGS studies confirming the monoclonality of the plasma cells is also required at diagnosis. And this is also needed to declare complete remissions or basically confirm MRD negativity. And also this clonality assessment either through NGS or through flow cytometry is also required as a yearly follow-up to continue a remission or to look for relapse. Also, cytogenetics and karyotyping is a very important part of the initial diagnostic testing and is needed to confirm relapse, but it is not required for follow-up. So things that we are looking for is the karyotype itself, and then a few translocation involving the IgA gene, especially the 14q32 region. So we'll talk about those in details. And then NGS and gene expression profile is needed for clinical trial, but gene expression profile is not needed for diagnosis or for remission or for relapse. So let's talk about the molecular biology a bit. So essentially, this is a disease of clonal B cells producing aberrant antibodies. So we are not going to talk about the antibody or the spike protein that's from the biochemical side, but we're going to talk about the aberrant B cells or the clonal B cells. So let's start from B cell differentiation. So we have the primary differentiation at bone marrow. We have the pro-B cell, which goes through IgA's rearrangement, which actually these are the two things that happened at the heavy chain locus. There is a stochastic IgA rearrangement at the D and the J region first, and then this D and J rearranged loci is actually recombined with the V loci or V region in the gene. So this was discovered by Dr. Tanugawa, and for which he received the Nobel Prize for Physiology and Medicine in 1987. And that produces the pre-B cells. Now, pre-B cell, at the pre-B cell level, there is recombination at the Ig light chain kappa gene first, and then at the lambda gene next. So at each step, the cell tests for the productivity of the clone, seeing its viability and testing its proliferation, and also its role in producing the antigenic diversity. That is the primary reason why this is happening. And this is all happening in a stochastic way, in antigen independent way in the bone marrow at this point. So that's why after the IDH rearrangement, the light chain kappa rearrangement happens first, and then more than 60% of the clones of the B cell actually has the kappa variant of the IGs, and then 30% gets the lambda variant, because whichever rearrangement is aborted or kind of energetic, that's when the lambda there's scope for the lambda rearrangement. So that is the last thing that happens. So the quota is already filled, but the last quota is being filled by the lambda. That's why there is less expression of the lambda in the end. So we have the immature B cells now with the rearranged immunoglobulins, but with the IgM flavor, with the pentameric flavor, with now it actually has also it starts expressing the IgD, which is known as the mature B cell. So this is all happening at the bone marrow level. Now at this stage, the B cell travels out and ends up in the secondary lymphoid organs, where the second most important part of the antigen-dependent differentiation takes place. Here, the centroblast, as the initial cell is called, is kind of nurtured at the germinal center of the lymphoid follicle. Here, two things happen. One is the somatic hypermutation, which adds a lot of antigenic diversity, and this is something happens at an alarming high rate at the germinal center. I don't remember the exact number, but then this is happening at a very high rate, the somatic hypermutation. And then at the end of the somatic hypermutation, the class switch happens so that the type of antibody gets fixed as well. So it is believed that the present hypothesis, there is some controversy about it, but the present hypothesis is that the oncogenic cell for multiple myeloma, or the mother cell for this process, arises at the end of the somatic hypermutation and around the time of class switch. So basically, somatic hypermutation is the process that gives rise to this oncogenic B cell, the clonal B cell that gives rise to multiple myeloma later on. So let's talk a little bit of somatic hypermutation, exactly what is happening. So the most important enzyme for somatic hypermutation is the cytosine deaminase. So the B cell at this time is it's kind of selecting the antibodies, producing this diversity, and thus is producing lots and lots of immunoglobulins. So IgH locus, IgLK, lambda locus are kind of highly transcribed at this point. So the transcription bubble is essentially always open. It's basically a constitutively active locus at this time. So the cytosine deaminase is actually a deaminasing enzyme that actually works on this locus preferentially because these are open locuses, open loci. So now we have this uracil happening in this loci at a pretty high rate. There's two ways the cell can handle this mismatch. One is not worry about it, just go through faulty replication, thus creating more and more of this mutation, and which is actually the hypermutation pathway, so that there is more diversity of antigen. And the second pathway of correcting it is using the uracil glycosylase enzyme, and thus creating an abasic site here. And then later on, the polymerase can actually transcribe that, giving rise to any complementary base. So it creates a kind of an N site, a unique site. The other pathway is the most stringent or high fidelity pathway is the MMR pathway. The MSH proteins identifies the mismatch, recruits the MLHs and the PMSs, and then and basically cleaves it through exonuclease, polymerase repairs it. And so if the MMR pathway happens, the fidelity of repair kind of goes high. So it's always a balance how the error, the mismatch is being repaired. That gives rise to either hypermutation or there's a high fidelity. So if there is error-prone replication going on at baseline, sometimes the HFR, the high fidelity replication happens where there is no kind of mutation that are being accumulated, but this happens very less. But then when the cell is under stress, the balance again tips over to an error-prone repair pathway. So this is how the mutations are being generated as a great number in these activated B cells. So not in the activated B cells, but then this clonally selected B cells. And now one of these mutations actually hit the right regions, and you have this ancestral clone. The ancestral clone happens at the germinal center, at the B cell level, during the antigen dependent selection or energy process. And there is also the subclone evolution during this process as well that happens on this primarily formed clones. So what are these primary ancestral events? They're essentially two primary ancestral events. First one is the hyperdiploidy, which happens in 55% of the multiple myeloma ancestral clones, which actually hits very particular chromosomes, 3, 5, 7, 9, 11, 15, 19, 21. These are the chromosomes that shows hyperdiploid numbers. And the second event, which is mutually exclusive, happens in less than 50%, so 45% of the multiple myelomas, which are the IGH gene rearrangement areas, which is the 14q32 locus. And there are multiple partners. We'll talk about that. And then there are the secondary clones that happens, and we'll talk about that as the disease progresses to myeloma, relapse, and extramedullary phases. So let's talk about these key molecular events. Hyperdiploidy myeloma characterized by basically the aneuploidy or trisomies of these chromosomes 3, 5, 7, 9, 11, 15, 19, 21 has been seen in 55% of the multiple myeloma cases, and studies have been done to look at the gene expression profile of this particular hyperdiploid multiple myeloma, and it shows an overexpression of the CTA or the proliferation classes of genes, which is the cluster 1 shown here. Cluster 2 shows an upregulation of inflammatory pathways genes, shown as cluster 2. Cluster 3 shows particularly anti-apoptotic and NF-kappa beta pathway, which is also a pro-inflammatory pathway genes. And there is the other cluster, which shows kind of like no distinct signature. But this is one of the pathways that are being proposed as the hyperdiploid, downstream to the hyperdiploid event. So why this hyperdiploid event happens in the first place? So this comes down to chromosomal missegregation. So either there are two key events, mechanisms that can happen that can give rise to this. One is the chromosome lagging, when there is some defect in the tubulins or the microtubule structures, where there is a delay between the chromosome separation at the anaphase, and then one of the sister cells, one of the daughter cells end up with like having half of the chromosome, like shown here, which rise to this partial aneuploidy situation. The non-disjunction is a known phenomena where there is kind of uneven distribution of the chromosomal fragments in one or the other daughter chromosome, and ending up in like triploid or aneuploid cells. And the other interesting mechanism has been proposed, and this has been actually well studied in ALL situation, where there is a defect in the aurora kinase, or there's a loss of the aurora kinase gene locus, which leads to either kind of the basically hyper not done in the proper way, and that actually affects the formation of the mitotic spindle, the anaphase plate, the cells end up in here, the chromosome end up in here, not being within the anaphase plate, and when they and the spindle assembly complex or spindle assembly checkpoint pathway is also impaired because sorry, audio stop. Okay. Yeah. Can you hear me now? Hello. Hello. Hello, can you hear me? Hello.
We can hear you now.
Okay. And okay, sounds good. Good. Okay, sounds good. So was it at this slide that things got things stopped, or should I move back a bit?
Dr. Hello?
Hello, was it at this slide, or should I go back? Should I start from this slide, or sorry? Okay, let me start. Let me just go on.
Someone wrote, yes, look on the chat. They're saying this is a slide.
This is slide. Okay, sounds good. Okay, so here we were talking about the non-disjunction. Yeah, it's the aurora kinase that that kind of it's not there, and then we have the mitotic assembly not happening in the correct form. I don't know my. And then what are the 14q32 translocations that are characterized here? So the first one, or the most common, is the 1114 translocation, which happens in 25% of multiple myeloma. Here, essentially, the IgH enhancer goes and sits next to the cyclin D1, thus overexpression cyclin D1 expression. The second most common translocation is the 414 translocation, which happens to 12-15% of multiple myeloma, and this is from the seminal paper in 1998. We talked about this translocation. Here, it is a very interesting translocation, and then there are two functional derivatives that are being formed. And in the first derivative, the enhancer, the IgH enhancer, actually drives the expression of FGF3, which is a receptor for FGF growth factor. And then the other one drives MMSET. So MMSET, it is a set domain protein found described in multiple myeloma. It is actually a histone methyltransferases. Interestingly, it goes back to actually regulate the cytosine deaminase and the class switch pathway. It's kind of a self-feeding pathway in that sense. The other translocation is 1416, where which happens in about 5% of multiple myeloma, where the IgH actually drives the expression of CMAF, which is a modulator of mTOR pathway and anti-apoptotic proliferative pathway. Next, we have this normal plasma cells which acquire this cytogenetic abnormalities from the fact that this genetic hypermutation is happening, and that's why the detection of abnormality, and they kind of stay here at the lowest or the molecular gammopathy of certain significance or the spontaneous multiple myeloma stage till they a secondary cytogenetic or abnormalities or secondary event that pushes it to a bigger form. This takes place on timeline wise, it takes place in 5 to 10 years time from this to distance. And previously it goes back to the basic oncology phenomenon of oncogene-induced senescence that actually stops the disease at the secondary myeloma stage. Yes. So once the oncogene-induced senescence it's still there, so that the cells kind of exist in the MGUS and SMM stage with the initial hit. And then you have to have the second hit. The secondary events happen. One of the most important secondary event is the 1Q gain or amplification. This 1Q region actually hits genes like CKS1B, IL6R, ILF, MCL, and BCL9. So these are involved in disease progression, multiple myeloma survival, and genomic instability. Specifically, CKS1B, it inhibits the P27 protein that derails the G1-2S pathway progression, and then BCL9 is actually a part of the beta-catenin enhanceosome when at the Wnt pathway effector molecule at the effector step. So other secondary events is the 16q deletion, which leads to a P53 loss. We also have high rates of KRAS and NRAS mutation. You can also see TP53 is again being affected as a secondary or tertiary event in a truncation or a missense mutation. And also there are other genes like ATM, ATR, cyclin D1, the RB, those are all affected in a secondary event. So now this gives rise to the idea of the double hit myeloma, where you have the first hit of the TP53 gone because of the 17q deletion, and you have the secondary TP53 missense or truncation, or there is a 1q amplification, which is like 3 or more copies of 1q. That kind of qualifies as the double hit myeloma, which are kind of the high risk myelomas we'll discuss later. And then there are also the secondary MYC translocation. Here, you can see that the MYC and IGH both are kind of promiscuous genes in terms of their translocation partners. And then the thickness of the lines actually depicts the frequency of this translocation that happens in myeloma. So IGH, cyclin D1, IGH, MYC, or MYC, along with other partners like IGL, FOXP, IGK. Here the FGF3 MSET is described here. These are all seen as primary and secondary events. Interestingly, the genes or the genes marked in orange are the genes that are also affected as a secondary process in this myeloma pathogenesis, which kind of arises the question of oncogene addiction, where once we have the amplification or of one gene, secondary mutations kind of pile on the same genes, because now this is the driver for that cancer. So now the checkpoint is gone, and then mutations kind of try to accumulate on this gene. So this is the oncogene addiction that can explain why secondary mutations can also take place in the same gene in multiple myeloma. Now it brings us to everything kind of draws to the G1-2S phase as usual. So you have the initial tumor initiating events and the translocation of the IGH, also the hyperdiploides that leads to the cyclin D1, CDK4, the complex dysregulation cycle D3 also is affected directly by this, or secondary event CKS1B or MYC. And then basically everything kind of disrupt the G1-2S checkpoints, and thus there is a G1-2S progression. So now we have this initial events, hyperdiploides and IGS translocation gives rise to mutually exclusive clones, which progresses to MGUS and SMM through secondary events. Now we have a mix of these clones, which shows either unique or overlapping secondary events, and this huge clonal heterogeneity, which kind of shows the spectrum of the disease in multiple myeloma and also affects the outcome. This study was done in Europe. They looked at 329 patients of multiple myeloma, and then they looked at the clonal heterogeneity. In this case, the SKY92 is the gene expression profile that is done in Holland. So you have this gain 1Q, deletion 16P happening exclusively in 46 or 22.5%, 6.4% of patients, but then there's a huge overlap in this, almost like 20% has this overlap, and also other translocation is kind of overlapping. So basically it's important. This kind of comes into the whole rationale of the testing that we done. So we are looking at the clonality of the plasma cells, because there are multiple clones that are happening at the time, both at the time of the diagnosis, but also at the time of follow-up, because either one clone or the other clone can proliferate later on, because there are so many clones that are being generated because of the somatic hypermutation pathway in the first place. And also this cytogenetic and karyotyping is the most important thing to do, because that actually kind of talks about the initial clones that gives rise to the anybody has any questions? We can stop for that. Yeah, I mean that actually is the initiating event from that point of view, and then it is not used for follow-up. But again, at relapse, because it can be that ancestral clone again coming back, or a second ancestral clone that goes through selection pressure and developing other mutation. So this is again needed at the point of relapse, but not at the time of follow-up. And then gene expression profile is only needed for clinical trials. So this is the gene triage protocol that we follow here at our MDL lab. So we test for billable genes, BRAF, FGFR3, KRAS. The FGFR3 is the initial ancestral clone. KRAS and TP53 is a secondary event. These are all secondary events. We look for that. We look for the minimum 10% of plasma cell count because of the sensitivity of our assay design. And we do the end leukemia panel. FGFR3 is not currently available for testing, but the other genes are actually available for single gene assay. So all this molecular pathway, does it even help in risk stratification? So what's the benefit for the patient? Studies have been done that shows that the amplification 1Q or the CKS1B gene amplification shows a worse prognosis, worse overall survival and progression-free survival than compared to basically gains, which are 2 copies or normal for this locus. So here the gray bar shows the worst prognosis in this Kaplan-Meier here. Similarly, this is talking about del17P or TP53, which not surprisingly, as it happens in many other tumors, has a worse prognosis overall survival over progression-free survival. ATM and ATR mutations also confers for a poor overall and progression-free survival as well. So this kind of ended up in making an overall risk stratification strategy. So this paper talks about this low-risk patients defined as no 17q loss, TP53 loss, no T414 or the cyclin D1 translocation initial event, and the no T1416 or the c-MYC event, initial ancestral event. So these are the low risk patients. So these are essentially the hyperdiploides that we talked about. And then immediate risk can have these mutations, but no double hit. And when we talk about double hit, we talk about the TP53 completely gone, both locuses, amplification of 1Q, and so on and so forth. So you can see there is a significant differences in progression-free survival if the patient is stratified according to this strategy in this study. And then, so what is the therapy? So standard of therapy is The standard risk or the trisomies of the hyperdiploides gets the VRD regimen as they wait for stem cell transplant. On the other hand, the high-risk patient that we talked about, the double hit and triple hit, and basically the cyclin D1s or the MAF patients, they get DARA along with VRD when they're waiting for the transplant. On the other hand, transplant ineligible patients, maybe from a standpoint of frailty index, failing frailty index and other reasons, they get the DRD regimen until progression, or get the VRD regimen, and then for the high risk one, get the VRD regimen, and then switch to a single drug for maintenance till progression or relapse, or essentially tolerated. So what are these different targeted therapy, and how do they kind of plug in the mechanism? So the VRD regimen is essentially the bortezomib, the lenalidomide, and the dexamethasone. The bortezomib is a proteasome inhibitor. Lenalidomide is basically an immune modulator, which works at the level of CUL4A, IKZF, and this pathway. And dexamethasone, we know, is kind of a standard therapy for tumor agnostic. And the DARA VRD regimen, where the daratumumab is added, which is basically a CD38 inhibitor, is added to this VRD regimen. And other proteasome inhibitors like carfilzomib can be used in exchange of bortezomib as well. And there are more drugs. There are a lot of other options at hand that requires a discussion of its own, presentation of its own, possibly. So what are the challenges at this stage? So the biggest challenge in the treatment is that the different clones that exist in multiple myeloma, essentially starting from that process of somatic hypermutation. So we have this one ancestral clone giving rise to the MGUS, and now this MGUS, the B cell is active. Whatever the ancestral B cell is there, it is active. It is again going through somatic hypermutation in the germinal center at this point. So this picks up different mutation. Maybe this is the 17q lost, TP53. Now it goes on to get other mutations that we talked about, BRAFs and secondary TP53s, and then move to multiple myelomas, which again, because of the high rates of turnover, getting new mutations. So we have this huge diverse clone that exists here. And then these are the extramedullary plasma cells, which might have a different clone as well. So now the treatment actually kills them all, but if there's a relapse, then one clone survived. And then this one clone that survives again becomes the ancestral clone, gets onto the same pathway from here. So this is the challenge. This is what we talk about, the clonal tide here. So this is the tides and tides of clone being produced. The disease progression from the initial event, the treatment happens, one clone survives, again, the same process comes back with 4 or 5 different clones. Or here, the disease progresses at this stage, the treatment doesn't kill off any of the clones, but then reduces the number of it, and then this time it comes back. So this is the challenge of the multiple myeloma. That is why we have so higher rate of early response as well as overall relapse. So what can be done at this point? So I think, so this is a paper that described in 2012 that
I think there is a problem in the sound. Sorry for the interruption.
there is a problem in the sound again.
Yes, we cannot hear you clearly.
Can you hear me better now?
Not really.
Hello, is this better? I can't probably stop my video and try to speak to you. Yes, let me know if this is better. Hello?
Yes,
Okay.
I'm still hearing some background noise.
Hello. Is proposed by this paper is to kind of identify the clones to the variants. And whenever we are getting a patient of myeloma, when we are looking at this sample, then when we are following it up. So this paper showed that the normal cell, which had a common ancestor, and this was the signature of that common ancestor, which showed the 15 shared CNVs in the common ancestor. When the patient kind of relapsed, or so at the time of diagnosis, was also shared these two other CNVs. So 6 CNVs and this one unique CNV that was there at the diagnostic stage only. And based on the VAF, it was proposed that this 15 shared CNV was the common ancestor, and then these two are the secondary events that happened. And then at the time of relapse, the first relapse, the ancestor was there, but it picked up unique CNVs. Second relapse, again, it showed the similar clones to the first common ancestor at the time of the diagnosis. And the third relapse had a unique clone. So you can see that here in the second relapse, somehow the first clone came back and it was not there in the first relapse. So it's kind of a challenging situation to even tailor the therapy to the clones, because like even if the therapies like was there in the first diagnostic first phase, that kind of created a second relapse or a second different clones which went away, and as first initial clone came back, and so on and so forth. So I mean, these are the diagnostic challenges, but then there are ways to kind of try to identify the clones in the first place, even if you're not following up the patients and the patient has the initial testing done. There are computational strategies and AI based strategies that can actually talk about the natural evolution of the clones, which is the ancestral clone, or the selection bias, which happens during the time of the antigen pressure during maturation, or during the therapy, which clears the subclones or relapse clones. So looking at a patient's VAF in the first place, and then using some of the strategies to know where is this clone coming from, is it ancestral, or is this some of the secondary clones, or a tertiary clone, or something, or a subclonal population in that way, trying to form an idea of the process in that patient in the first place, can help us strategize the therapy better at different point of time in this patient. And similar, or another way is to do a methylation barcode, because methylation is basically a signature for each clone. So maybe we do a methylation profiling and then somehow kind of barcode it, or like, it's not barcoding, methylation is the barcode. Look at the NGS at the same time, and then we know that this was the methylation profile when we did the NGS for the first time, and now we are doing it, and this is the methylation profile. So this is this clone, and this is that clone, and we have an idea of which clone kind of took over at what point during therapy, or what point during relapse, during the multiple relapse events that happens in some of these multiple myeloma patients. And also the current study trial designs is actually kind of this clone agnostic, so, or even like risk agnostic. So all patients get a novel agent plus standard of care versus a standard of care. And then the study and analysis is actually geared towards a subgroup analysis, standard risk versus high risk, but the enrollment is not. So that also poses challenges in its own ways, because biostatistics is only that powerful. If the study is going to be powerful enough, the study design has to be right. So now this is these studies are in phase 2 and phase 3 trials now, where the high-risk patients are getting a different standard of care and a different novel agent compared to the standard risk patient, which are getting different standard of care and different novel agent in the first place, so that there can be better outcome management or outcome analysis for these groups, so as to come up with novel methods for therapy in these patients. The potential study design can be actually mutation specific. So the standard of care, some patient gets the standard of care, some patients gets targeted therapy based on individual mutation profile for each of these patients. If this can be done, that might be a new way of going forward for this patient, for developing new strategies as well. So this brings me to the end of the talk, and I would like to acknowledge Dr. Patel to having me or giving me the opportunity to present at this TCGA conference, and also choosing the topic for me, because this is something that I'm not very familiar with. I am trained in epithelial biology and then anatomic pathology, but then this was a challenge for me, and I learned so much from this process. And especially Dr. Jalul, who helped me identify the high impact publications in this field, so as to basically tailor my presentation as well. So like a vote of thanks for them. And with that, I will take questions, and I can provide the bibliography on request. Thank you very much. Let me know if anybody has any questions. Okay, if there are no questions, we can.
I see Dr. Oak is raising his hand.
Okay.
Include so the FGFR3 gene is sequenced under this
Okay.
panel.
Okay, it is there. Okay, sounds good. Thanks.
And the advantage of it is that we can also use it on bone marrow clot sections. So we can use it also on FFPE.
Yeah.
If there are no further questions.
So the oncogenic senescence and persistence of clone contributing to relapse associated with treatment. So yeah, oncogenic senescence that can happen during the initial part and also during treatment. So treatment also induces oncogenic senescence. And I mean, so I don't know if the oncogenic senescence can contribute to the relapse, because it's actually kind of the protecting mechanism from relapse. But then yes, somehow some of those clones escape the oncogenic senescence, and which kind of expands later on, because now they are not under any kind of stop from the cells, kind of stop signal from the cells to kind of divide. So yeah, so the clones that I would say that escape the oncogenic senescence induced by the therapy contribute to the relapse. Yeah, you can say it that way. I don't know if that makes sense. Thanks very much. Okay, if there are no further questions, let's stop here. And then I think next week we have Dr. Roodbort for the